Hello students, good afternoon.
Good afternoon, ma'am.
Good afternoon, ma'am.
Can I start? Do you still remember the nasogastric tube insertion which we discussed in the clinical? What is nasogastric tube? Can you hear me?
Yes, ma'am.
Okay, now why do we use nasogastric tube for?
Ma'am, for providing food.
And what else? Have you ever seen patient with NG tube?
Patient is unable to take oxygen properly.
Nasogastric tube is not for oxygen. Oxygenation is nasal cannula, no?
Ma'am, like Riles tube.
Nasogastric tube is Ralph's tube. So what is the purpose?
Ma'am, for providing food if the person can't means take food by
Okay,
mouth.
for providing food, then what else? Because
Medication
Medicine also, ma'am.
for medication,
for
food,
providing medicine.
because this has been discussed in the clinicals, no?
Yes, ma'am.
Yes. Anyway, let's go with the class. We'll start, okay? Okay, so nasogastric tube is a common practice. Nasogastric feeding, as you all said, it is used for feeding, no? So it's a common practice and many tubes are inserted daily without incidents. However, there is a small risk that the tube can become misplaced into the lungs during insertion or moved out of the stomach at later stage. So because of all these things, usually when we give nasogastric, we do it nicely. Then we can feed the patient, we can do suctioning, we can give medication, we can check the stomach content, or sometimes misplaced or the tube can go somewhere else. For that, knowledge on nasogastric tube insertion is important for our nurses. How do we measure nasogastric insertion? Before inserting, we need to measure the tube, right? So how do we do? Yes, please someone help me out.
Ma'am,
Yes.
from tip of the nose
Yes.
to the ear, ma'am.
To the ear what? Which part of the ear? You have to measure it properly, no? So tip of the nose to the where?
To
Ma'am,
the
outer
earlobe.
ear.
Yes, earlobe. Okay. Then where?
Ma'am, after it, from ear to the Zigfoid process, ma'am, of the stand.
Xiphoid process. Okay. Then anyway, these days the tube is already marked up to which part we have to insert the tube. Okay, it is easy. But anyway, before doing that, we usually try to see, measure and see whether it is okay or not. Okay, from our side also. So this one. Can you see the slide?
Yes, ma'am.
Okay.
Yes, ma'am.
So
Yes, ma'am.
from the tip of the nose to the earlobe here. Okay, and from the earlobe to the xiphoid process. So after measuring it, it will go inside. This is pharynx. It has to go inside the pharynx, not the larynx. No? If it goes inside the larynx, then it will go to the lungs. So we have to be very careful while inserting. Now, can you see?
Yes, ma'am.
Okay. Nasogastric tube is made of silicone or the material used to make nasogastric tube is silicone or polyurethane, which is passed through the nostril via the nasopharynx into the esophagus then the stomach. Okay? Nasogastric tube used for the purpose of feeding must be radio opaque throughout their length and have externally visible length marking. Okay, so what is the advantage of radio opaque? Used for the purpose of feeding must be radio opaque. Why? Can you tell me why? Roll number 40. Who is roll number 40?
Yes, ma'am.
40. Okay, otherwise Madhav, can you hear me?
Yes, ma'am.
Yes, you tell me. I think you were absent in this class while in the clinical class was going on, right?
Yes, ma'am.
Yeah. So nasogastric tube is used for the purpose of feeding must be radio opaque. Why radio opaque? Madhav, you listen and someone will answer now. Okay, Debajyoti Roy. Debajyoti Roy?
Yes, ma'am.
Yes, tell me why it should be radio opaque.
Ma'am,
Ma'am,
we have to see in X-ray also.
Yes, very good. Okay, radio opaque so that it will not go through. When we take X-ray, we can see the bones. Yes, we can see like in the same way. This it should be radio opaque so that when they do X-ray and they wanted to see the the X-ray lights will not go through it. Okay, so we will be able to confirm where the tubes are. If the X-ray lights rays goes can observe and goes in, then we will not be able to see where the tubes are. Suppose there's we give nasogastric tube, then patient is having some problem, but we are not trying to finding out, like we are not able to find out what is wrong with the tube. Then what will happen? Then when we confirm in the X-ray, we will see that the tube has gone toward, slightly shifted towards the lungs or towards some tube, something else. It is not in the stomach. Because of that, it has to be radio opaque. Okay. Then now the purpose, as you said, to feed with fluids when oral intake is not possible, to dilute and remove consumed position, to instill ice cold solution, whatever, like this is to purpose is to feed, to do medication, to provide medication, okay, to do treatment, and to prevent stress on the operator side by decompressing, then to relieve vomiting and distension. That means how to relieve vomiting and distension by suctioning out, okay, and to collect gastric juice for diagnostic purpose. When we take out the juice from the stomach, then we can send it for investigation. So that is for to feed, for treatment, to relieve stress, to relieve distension, and for the diagnostic purpose. These are the reason or the purpose for NG tube. Okay. So selection of NG tube. Select the fitting tubes based on the tube's composition. Intended. Use estimated length. That means we have to use the correct French size for adult, for children. Like the different size are there, so we should be able to measure it and see. Then what size you will come to know when we use it regularly. Okay. Then equipments required for NG. So if you are asked to prepare a tray for NG tube, for example in exam, you were selected for this procedure. So if they ask you to set the tray, suppose you did not get the patient, you will go and tell your madam or the teacher, externals, no patient is available, but then the external might just tell you, go and set the tray. Then you should be able to set the tray, no? So a non-sterile disposable cloth and a syringe, 20 to 50 ml, then pH indicator strips if available. Okay, this is if available. Then lubricant. Then in our hospital we use xylocaine gel. Okay, xylocaine gel. Then safety pin is exactly the word safety pin means to any tap that we use in the hospital. Okay, kidney tray, tissues, towels, and again adhesive tabs. Okay, these are the articles that you will be requiring: glove, syringe, tube of right size, lubricant jelly, cup of water or ice, then if we have to do drainage bag. These are the articles, not mandatory all the articles, but these are the articles that we use. Okay, and secure the device or tap. In this way we used to, I think you have seen the patient with NG tube, how the taps has been secured. Yes or no?
Yes, ma'am.
Then we need a
Yes,
torch
ma'am.
or pin light. Okay. Okay. Then what you will do before starting any procedure, what we need to do is we need to,
What?
then what else you'll do?
First, we wash our hand.
Then wash your hands before.
And then we'll confirm the patient and position the patient.
Yes, very good. Then
Mark the distance of the tube.
hmm,
After that, lubricant the tube of about 6 to 8 inch with the lubricant using a raised pieces of a paper square.
then
After that, hold the tube coiled in the right hand and introduce the tip into the nostril.
so wash your hands means before that your articles has to be ready. Okay, you have to assess
Yes,
the
ma'am.
patient first. Then articles has to be ready in besides the bedside. Stand on the right side of the patient. Wash your hands thoroughly and do the procedure as it is written now. Okay. Then after that,
Yes.
pass the tube gently but quickly backward. Momentary resistance may occur as the tube is passed into the nasopharynx. So in order to help us to, and what is the, when you position the patient, at what degree? 90 degree, the patient has to sit up, or which angle? Which angle I mean? The patient would lie flat or lie straight or half sleep, how?
Ma'am, half sleep.
30 degree, no? 30 degree, okay. So when the tube reaches the, and then in order to, while passing, it should go to the nasopharynx, not to the nasolarynx, no? So what you will do, you will tell the patient to swallow. Try to tell the patient to swallow. Okay, when the patient swallow, the epiglottis, it opens, that one, no? So it will help, when it close, the nasopharynx, when you swallow, the nasopharynx will close, and then this, the tube will go to the nasopharynx. Okay, the larynx will close, so the tube will easily go inside the larynx. Okay, but otherwise sometimes we use sips of water also from the side, so that when the patient is about to swallow, that time swallowing, that time we insert the tube. Okay, when the tube reaches the pharynx, the patient may gag. Allow him to rest for a moment. And have the patient take the sip of water on the command. Advise the tube 3 to inches each time. And we have to advance 3 to 4 inches each time which the patient swallows. Make sure that the tube is in the stomach. Once location on the NG tube inserted close and other end of the tube is because secures tube on the nose using the adhesive because once the NG tube is inserted, how will you make sure that it is in the stomach? Yes, you already know. Tell me how to make.
Ma'am, will
Uh,
aspirate with syringe, and if it green color come out means it is in stomach.
okay, then
Green liquid.
and what else? What? How will you other indications? One is you have to aspirate. Okay. Then next, what are the other ways you have been taught with the stethoscope?
Ma'am,
Thing you do, no?
yes, ma'am.
Yes. What you do? Yes. Put position the stethoscope in the stomach area. Then pinch the tube. Then insert. Then you use a 2 cc or 5 cc syringe. No. Then you push air, then listen when if the sound is coming there. Actually that is usually not practiced nowadays, but it is also one method if need be, if we have to do. Okay, then we will listen to the stomach with the stethoscope. Then if we hear that sound, that means the air is, that is the tube is in the stomach. Okay, then again we can put, they used to taste the with a litmus with a this one, what paper we said, that one indicator, no? Then if we taste it, if it's acidic, I will show you in the next slide. Then what else we can use, in a bowl of water and put the tube and taste. If bubbles comes out means it is in the, if bubbles comes out, then where it is? What do you think if the bubble comes out, if you taste the NG tube, if you dip the in the water? Yes, students. Can you hear me?
Yes, ma'am.
Yes, ma'am.
While doing oxygenation, we used to taste before giving oxygen. Yes or no? In the bowl of water. Then if the bubbles is there, what does it indicate? What does it indicate before giving oxygenation?
Ma'am means air is present.
So oxygen cylinder is empty or
Okay,
not? We first
ma'am.
check. No. Then if the bubble comes out, that means oxygen is there and we can administer to the patient in the oxygenation time. Now in your NG tube time, when you insert the tube in the water and if you see, and if the water is, there is bubble, that means there is something wrong. NG tube is towards the lungs. If it's towards the lungs means oxygen leak will be there. Yes or no?
Yes, ma'am.
Yes. Anyway, if the tube, one thing you have to know is, when we insert the tube, Okay, when it reached the larynx, when it is about to reach this one, larynx area, larynx area, if the tube by chance goes into the larynx side, then the patient will start having difficulty in breathing. The patients might have some, like, no, the face will become a little bit dark, something like that, because when there is no oxygen, we can make out, no? So that one will happen immediately, and the patient will start, like, no, difficulty in breathing, restlessness. Immediately we will of course come to know when the tube is not going inside the right track. That one too we will know only. But these are the different methods that we test whether the tube is in the stomach or not. That are the different methods that with a stethoscope, then we have to aspirate and see all those things. But immediately we will also know if it is doesn't go into the pharynx, then the patient will have restlessness and will show symptoms of difficulty. Okay. So immediately when the patient is that way, then you have to remove, draw back the tube immediately, and we have to reinsert it again. Clear?
Yes, ma'am.
So when we say nasogastric feeding, that means it is the delivery of nutrients from the nasal road into the stomach via a feeding tube. Nasogastric feeding means delivery of nutrients via nasal road into the stomach through a feeding tube or via feeding tube. If someone asks you what is nasogastric tube is different, nasogastric feeding, if the definitions will be different, okay? So this is the way we follow. First we will select the tube size, the right size, then place the tube in the right position, then whatever we have to do, administration of the feeding, formula like for feeding or for medication. After that we have to administer and monitor and documentation to be done. Okay. So this is also one method. A combination of aspirate, appearance and pH testings can be used to help make correct prediction about the placement of the stomach. Okay, pH value will also indicate, suppose a pH less than 5 will indicate that it is in gastric, it is in the stomach, and it will proceed to feed. pH 5 to 6, check visual characteristics of aspirates. Then we will proceed to feed after the indication. Then more than 6, intestinal or respiratory, do check for X-ray to confirm the placement. But usually in the hospital, what we do is we will do the aspirate and we will see. Okay. So when are you supposed to check the placement? Mark the insertion when the nasogastric. So when you do the insertion of the tube, we have to document it when the insertion was done. Okay. Then after the insertion, after you insert the tube, what you will do is, after that everything is ready, you insert the tube, then put a plaster on the nose and close the tube and keep it ready for the use. Then in that time you have to mark it near the nose, or there will be a marker or something is there that you should know up to which point the tube has been inserted. Okay? Then after that, the next time or after 8 hourly or whenever you have to come for feeding or for suctioning or for medication, whatever, you have to see that mark area. It is near the nose, you have nostril, you have to mark it. So if it has slide out or slide inside, then you have to reposition the point where you have to bring it back to the point where you have marked it. That will show that whether if it's come out too much out of the nose, then it means it has displaced itself. No, so we have to reinsert it again. So that marker point is very important after you insert the feeding tube. Okay. And if the patient, when you have to check if the patient complain of discomfort, coughing, vomiting, and show sudden sign of respiratory difficulty, also you have to check again what is wrong with the tube. And this was what I was explaining. If the visible part of the tube changes in the length, it has become longer or it has become shorter, we have to again see what is wrong with the tube. So how to maintain the patency? Flush tube with 30 ml of water before and after intermittent feeding. So before feeding, always we need to flush it, we know that, after aspiration, and or every 4 hourly during continuous feed. Intermittent feed means some patients are we feed not continuously, no, hourly we feed. That time before, after we have to flush, or during continuous feed with a pump, syringe pump, continuous feed like the way we give injection continuously with a pump. Sometimes feeding is also done like that. Then every 4 hourly we have to flush the feeding tube. Okay, understood this point?
Yes, ma'am.
Yes, ma'am.
This you know. Before preparation of the formula feeds and delivery system, wash hands before preparing and handling a delivery set. Use masks if the handler has not. You have to use masks not when because of the patient is having cold, or if you yourself, that means if the person who is going to feed the patient or who is going to give the medication is also having cold, that means we should definitely use a mask so that our infection will not be transferred to our patient. Okay, limit the hang time. How long we can hang the formula? 4 hours for powdered reconstituted formula and enteral nutrition formula with additives. No, so anything with the medication we mix something and give, of with food we mix some vitamins. Those has to be hanged for 4 hours. 8 hourly for sterile formulas. 24 to 48 hours for the closed system, like all those IV lines, IV fluids we give. And these are the hours that we need to maintain. Otherwise, it will lead to infection and it will have problem with the patient. Okay. So while positioning the patient for feeding, patient should be placed at a semi-recumbent position or elevated to an angle of at least 30 degrees. Okay. We should never feed the patient on a flat position. Otherwise, it might lead to aspiration. Okay. Elevation of the head of the bed at least 30 degrees during the due feeding decrease the risk of aspiration of the gastric content. This is very important. We have to remember. Gravity reduces the likelihood of regurgitation of the gastric content from the distended stomach. So it also prevents regurgitation. Therefore, is evidence that a sustained supine position with the head of the bed flat increases gastroesophageal reflex and the probability for aspiration. So we need to maintain this. To prevent aspiration, we need to maintain the 30-degree elevation of the bed. What are the different types of feeding? Bolus. The total volume of feed. Bolus means at one time, now when we take that 50 ml syringe or 500 ml, 400 syringe, and we just push it in. That is called bolus feeding. Okay, that is called bolus. Understood? Bolus in one go when we feed. Okay. Next is continuous feeding, means as we told you, using the feeding pump. You have seen the syringe pump or not? Continuously, the patient used to get with a pump, no? Adjusted the timing and per minute, how many drops per minute, and continuously with a pump the patient used to get the medication. You have seen in certain wards.
Yes, ma'am.
Yes, like that feeding was also given. Okay, so number one was bolus feed, number two is continuous feed. Then so one is bolus, one is continuous feed. That much if you can remember, it will be nice. Okay, then how to manage feeding intolerance. When patients show sign of feeding intolerance such as nausea, vomiting, abdominal distension and pain, that time you have to assess the patient something is wrong. Then we have to perform a physical examination of the abdomen, including assessment of the presence of abdominal bend and bowel sound. Feeding should only be stopped abruptly for those patients who demonstrate overt regurgitation or aspiration. So we should not stop immediately the feeding when there is some problem, but we need to assess and perform physical examination to find out what is wrong. Okay. So gastric residual volume should be checked 4 to 8 hourly in continuous feed patient and before each feeding. And gastric residual volume greater than 200 ml, then it should be prompt careful bedside evaluation should be done. And reading should be evaluated in conjunction with physical examination for abdominal distension, absence of bowel sound, and presence of nausea and vomiting. When the patient is having distension, stomach pain, then we have to ask the patient whether bowel sound is present, like is there or not. Then we have to assess their nausea and vomiting also. Understood?
Yes, ma'am.
When the patient complains of anything else, you should not stop it immediately, but assess for the physical examination and find out how will you assess the bowel sound. How will you assess the bowel sound?
Through stethoscope.
Yeah, through stethoscope. How? When you listen, then there will be sound, making sound. Okay, the intestinal, the abdomen will, there will be a typical sound that we know. Or otherwise, we can ask the patient from the morning, there is any the passage of gas, they have fart. When there is bowel movement, if they don't pass stool, then the patient will pass gas. That means bowel movement is okay. Okay. But if the patient says no bowel movement and no nothing like that, and the patient is having full distended stomach, that means something is wrong with the blockage or some paralytic ileus, something wrong. So we need to find out and inform the concerned person. Understood?
Yes, ma'am.
So are you clear now?
Yes, ma'am.
Acha, before feeding the patient, what we need to do? Suppose you have inserted the NG tube, everything is ready. Now you are supposed to feed the patient. So how you are supposed to feed the patient? Huh?
And flash feeding
Yes,
too.
yes.
Flash the feeding too.
No, flush, not flush. First of all, you have to see that the tube is in the stomach or not first. So you have to do whatever way you have to see. And if the aspirate comes out from the stomach, that means it is in the stomach. Yes or no?
Yes, ma'am.
So you aspirate and see. Then suppose after 4 hours you are going to feed the patient. Okay. So morning 7 o'clock you have fed. Then 7, 8, 9, 10, 11. At 11 o'clock you have to feed again. So when you get ready with your everything formula and when you are about to feed, you have to first aspirate and see then if the gastric content is coming out or not. Okay. And if it's there, that means it is in the stomach. Yes or no?
Yes, ma'am.
Then you have to flush it again little bit. Then you will have to feed the or give medication. Then what you will do after that, after feeding?
After feeding, we have to flush also.
Yes, you have to flush and keep the tube clean. Otherwise, it will lead to blockage of the patency of the tube will be disturbed. Understood? Anything you want to ask?
No,
No,
ma'am.
ma'am.
Okay, then I will stop the class here. Okay. Thank you.
Thank you, ma'am.